I do know that my goal is to help support you as much as humanly possible with the content today. This was a great opportunity for you to get better educated and better understand all of the things that are related to endo and what your role can be in supporting these patients. So I want to talk about this integrative care for endometriosis. I want you to really deeply understand what evidence-based decision-making looks like in this patient population. And I do want you to remember that when we talk about like evidence-based decisions, it's not that we, only make decisions based on certain kinds of studies or we only use certain kinds of interventions. It's more that we have a framework for making decisions. Patients with endo have often been left waiting or left being underassessed, underdiagnosed, undersupported, and undermanaged, which gives so much opportunity for you to be able to support this patient population. And I'm going to talk through various levels of evidence today that you can support. Some of it is still in development and very early stages, like the application of things like melatonin. I want to talk about some of the conventional strategies and where they fall short, so where you can step in and be supportive. So when we say evidence-based, it's really about helping you understand your role, you understanding like a great decision-making framework to support this patient population, and then how to pick off the shelf the things that are going to maybe support your patient in the moment or wherever they are in their healthcare journey. So I do want to acknowledge just quick before we move into the content that all people can experience endometriosis. It can occur in all people and all genders. And the vast majority of the literature is capturing the experience of people who are assigned female at birth who identify as women. We don't have great information about the trans experience with endometriosis, although we can imagine that given their struggles in healthcare in general, that they're going to have more diagnostic delay, more chronic pain, and more challenge. We don't really have literature that specifically calls out that population. We also can see endometriosis in male patients who were assigned male at birth and identify as men, but I'm not going to focus on that in the talk today. It's a very unique subset of the population, and the literature is really quite minimal in that group as well. So I will be doing my best to use gender neutral language, but acknowledging that the vast majority of the language used in the research right now really reflects the cis population. So one of my favorite people, and honestly the best thing to happen to endometriosis since low FODMAP sliced bread, is Dr. Matthew Leonardi. He's an obstetrician out of Hamilton, Ontario. He's basically my next door neighbor who is really revolutionizing the diagnosis of endometriosis. So if you've been following this condition along for a long time, you'll know that the gold standard for diagnosing endometriosis requires laparoscopic surgery. I'll just say that again. The gold standard for diagnosing endometriosis requires laparoscopic surgery. So you can imagine the bottleneck that we experience in terms of accurately diagnosing people and then understanding patients with endo if we said, no, we don't know for sure if you have this unless you go under the knife. We're missing a huge percentage of people if we must do laparoscopy in order to confirm the diagnosis. And this is why patients with endo have such long delay in getting support, because we were waiting to be sure. The literature's really changed in two ways. One is we now know that non-invasive diagnostic ultrasound can be used to accurately diagnose patients with endo. I have a slide on it in a second, but that opens up a whole window for these patients to get assessed and diagnosed more quickly. We also believe that it is inhumane, essentially, to not give solutions and treatment to patients who don't have laparoscopically confirmed endo. Whereas in the past, we made patients wait, right, until we knew for sure. Where now you may see solutions being offered earlier, and that's actually to our patient's advantage. Now, Matthew has used the term, and I've coined it, and I've told him I've stolen it. Diagnosis is therapy. And the reason he says that is because until patients have a practitioner like you who correctly identifies what's going on with them, they never get onto a path to be better, right? Until someone says, you know what, I think this might be endo, that patient never starts to walk down a line towards being better. And so diagnosis is part of the treatment for endometriosis, because for the vast majority of patients, by the time they're assessed, by the time they're flagged, they have had 8 to 12 years of chronic pain. Okay, we also know that that diagnostic delay is one of the most significant contributors to the chronic pain experience of endo. So the longer that patients wait, the more their chronic pain has set in neurologically, and it makes them less likely to ever be pain-free in the future. So where's like maybe your biggest role in all of this is reducing diagnostic delay. And patients who are presenting in your office with significant period pain, you have to have in the back of your mind that this might be endometriosis, because up until now, we've really underestimated the number of people with endometriosis walking around in the population. This was a great study. It's a little bit older now, but I've used this study often to explain how even someone's age influences how long they wait to get accurately assessed. If you're in your 30s and you are being assessed for your pelvic pain, we will catch your endometriosis earlier, probably because we're investigating your unexplained infertility. Whereas our young and adolescent patients are waiting the longest to be properly assessed for endo, again, likely because we used to do laparoscopy to assess these patients, but also because we've normalized the menstrual experience of adolescence, that it's often painful. And like I said earlier, that chronic pain of endo is happening because of nerve sensitization. So if you've ever had a patient where they've had their lesion excised from their endo, and then 6 months later, they still have chronic pelvic pain, you know, for the most part, when we cut something out, things get better. When patients have had endo for a long time, their nervous system has adapted and changed to have a chronic pain experience. We know that this nerve sensitization that's happening in endometriosis is part of that chronic pain. We also know that that inflammatory, sort of cytokine-rich peritoneal fluid that patients have when they have endometriosis is changing the way their nervous system interacts with their nervous system, and it's affecting the way that they feel about their pain going forward chronically. Okay, so we're seeing this change in their nervous system, which means that even like minute changes to the way that their gastrointestinal system feels, right, like IBS, or the way they experience regular menstrual experiences is actually amplified pain-wise by these patients. And so we know that if we intervene earlier, if we diagnose these patients earlier, we maybe actually be able to change that central sensitization experience. This is an area that is growing. Okay, so this won't be the last time that someone ever talks to you about central sensitization and pelvic pain for patients with endometriosis. Really important for us to pay attention to, because again, if we decrease that diagnostic delay, we're likely going to change that pain experience for patients and prevent the chronicity of their pain. So they are much more likely to be able to experience pain-free days in the future. So again, these are just a couple of slides commenting specifically on why we think this is all happening, the inflammatory environment in the pelvis that we think is contributing. Again, we're going to see more about this in the future, and it really ties into our discussion around antioxidants and why they may be part of the solution for working with these patients. So a really sort of important piece here, and again, this is something that we were kind of made mistakes in the past, where we assumed that the staging of patients' endometriosis was a reflection of their pain experience, right? So if someone just had stage 2, we assumed that their pain wasn't going to be as bad as someone who has stage 4. You don't need to wait for staging of your patient's endo in order to treat them. And you also don't need to wait for staging of your patient's endo to acknowledge their pain, right? We treat the pain, we don't treat the stage in patients with endometriosis. It really doesn't correlate very well. So if you ever get a report back that your patient has had a biopsy, or they've had laparoscopy, or they've had an ultrasound, and it gives you an impression about how bad the endo is, you really need to ask your patient how bad their endo is versus relying on the imaging to help you make that decision. So let's talk about the history taking component, because like I said, diagnostic delay is our big issue here, and I want you to be able to actually change this metric for your patients. Like, imagine what would happen if we took diagnostic time from 12 years down to like 3, right? Like, what would happen to these patients if we did that? How much less medication would patients need? How much more pain-free living would patients have? How much less chronic pain and opioid use would we have if we reduced the diagnostic delay, right? Really significant. So I spend time on this. And sometimes, like I know as a clinician, when the lecture is about history taking, like your brain turns off, right? You're like, yeah, I know how to do this, Jordan. But I actually want you to listen. So turn those ears back on, take a big sip of your coffee, because when we have this diagnostic delay, it sets our patients up for chronic pain. We also know that the imaging that's required to capture your patient is not available everywhere. So yes, ultrasound is amazing, but you need a skilled technician and you need the equipment. And both Canada and the US have not done a great job at investing in that solution quite yet. So what that relies on actually is that primary care physician to be able to ask the right questions, because we can get awfully close to diagnosing someone with endo just by asking a few key questions. So when we look at question asking, this was a great study that was done that looked at like the pairing of symptoms, right? So we know if someone has menstrual pain, that doesn't necessarily mean they have endo, right? They might just have period pain. But if they have period pain and they have infertility, the likelihood of them having endo goes up significantly. If they have pain with their period and they have pain at ovulation, it increases the likelihood of endometriosis significantly. If they have pain with their period and they have pain with intercourse, it increases the risk of endo significantly. So I share this because we've all had patients who've had, been victims of the 7-minute health appointment, and they don't usually go into the level of depth of history taking that you have the capability of doing, right? This is why I think this is actually your job, because you can ask those questions. Pain with intercourse, pain on defecation, pain around ovulation, right? Infertility. Sometimes when we meet patients in their 40s, we never ask them about their fertility journey. We just focus on the period they're having now. But when we start to pair up these parts of the patient experience, we can get very close to having like a pretty significant positive predictive value here to try and rule in or rule out with that negative predictive value endometriosis. So again, these were the individual questions. This is when they started to pair them up. So pain during menstruation and infertility, right? Pain during menstruation and irregular periods. You can see as we start to take a more in-depth history, we can get closer and closer to diagnosing patients with endo just by asking their questions. Okay, these are a couple of other papers that specifically, again, we're looking at positive predictive value, negative predictive value of things that can be done at the primary care level. So this was one looking specifically at pain with sex, pain during the period, pain on palpation of the uterosacral ligament, and 125, which is a blood biomarker. The combination of those four things really increased the likelihood that patients had endometriosis. And that's before they ever had to walk in the door of an ultrasound clinic, okay? So again, really great techniques for you to be a great detective and help, again, decrease that risk of diagnostic delay in your patients. This slide specifically is sharing about an ultrasound. When you get an ultrasound back from your patient and it talks about ovarian lesions or a suspected endometrioma, again, the likelihood that that patient has endometriosis is very high. So these are great ways for you, right, in the back of your mind to say, how can I take control of my patient's situation here? A lot of it comes from you taking a great history, being really curious, and going through those questions systematically to figure out if we think this patient actually should be assessed for endometriosis. We don't quite have the machine learning yet on this particular topic. I love talking about the use of AI in medicine. We use AI in the Confident Clinician to help you move through our content faster. But right now, we don't have great decision-making algorithms for endo based on AI. So your history taking is currently where it's at. I mentioned earlier that the tide is shifting around diagnosis for where we used to do laparoscopy and we now can do transvaginal ultrasound. This is an amazing way for your patient to have a sort of low barrier to entry for imaging and also low risk type imaging. The challenge with diagnostic ultrasound for endo is that you have to be looking for it. So you can't find what you're not looking for on ultrasound. And quite often, a casual requisition for an ultrasound doesn't have the person look at the areas that we would want them to look, specifically looking for endometriosis. So really important that if you are going to try and communicate with a specialist, or if you yourself are sending for ultrasound, we need to be clear where we want our scanner or our ultrasonographer to look in order for us to try and find that sort of endometriosis in the pockets around the uterus, and of course on the ovaries, that might give us the clues that we need to understand if the patient has endo through ultrasound. Now, even since I gave this lecture last, almost all of the papers published on endometriosis in the last couple of years are about diagnostic ultrasound. So it's hopefully this emerging conversation and something that we'll see be normalized as part of standard care very soon. But as it is right now, okay, and like I say on this slide, there's a standard of care to look for a fibroid, but there isn't a standard of care to look specifically for deep infiltrative endometriosis. We need to try and communicate to the specialists, etc., that we can actually look for endo when we're doing these ultrasounds. Okay, as far as other assessment goes, I really wanted to hit home the history taking. CA-125 is a great blood biomarker that does show relatively good sensitivity and specificity for endo. The challenge is that a negative on this test doesn't rule it out. So some patients with endo don't make this glycoprotein and they aren't going to show positive. But if you have a young patient with painful periods who test positive for CA-125, that's almost a shoo-in statistically that they have endometriosis. I listed all of the papers about that here for you. And then of course, there's other things that we might assess in these patients. And one of them, maybe the most importantly, being vitamin D, because we're going to talk about that as an intervention a little bit later. AMH can be valuable. We know it decreases when there's ovarian involvement. We know that it decreases post-surgery, especially if there's ovarian involvement in the surgery. And then other patients may need to be assessed for anemia, blood loss, low iron, etc., because of the consequences of their endometriosis. Fixing their anemia doesn't improve their pain per se, but we certainly don't want our patients to walk around anemic if they are. I made a note here that hormone testing is not helpful in these patients. And so sometimes estrogen gets a bad reputation in patients with endo because the tissue itself is estrogen sensitive, right? It's also a bit progesterone sensitive, truly. Like it responds to our hormones, but our hormones are not the cause of endometriosis. Estrogen isn't the cause. If we suppress estrogen, it's often a solution when we look at drug therapy, but testing your hormones doesn't give you a heck of a lot of insight for these particular patients. And then I gave you, of course, a couple of other questions that you can ask your patients to help you best understand what's going on with them. The bloating and digestive symptoms and non-menstrual pain symptoms are important because it starts to help us understand that central sensitization. If patients have really significant everyday pain in their pelvic area, it's kind of more pointing towards endometriosis in those patients. Okay, so like I said, endometriosis is not caused by estrogen, but often estrogen is part of the solution. I did want to do a quick review of the medications. So in the past, when I've done this lecture on endo, it's difficult because I, working, hand in hand with the hospital, saw patients at all different stages of their endo journey. And I used to say, if you've never had a patient with endometriosis on medication, you have not worked with very sick patients or sick enough patients, because the vast majority of patients with endo, by the time they're assessed, by the time they're supported, they have chronic pain, and medication is a really amazing way for them to get quality of life back and for them to get parts of their life back that they have lost from this chronic condition. So I'm very pro medication in this patient population, but I also want you to know that medication prescription, if it's not coming from you, is maybe months and months away from the time that we understand this patient's situation. And you can intervene all the way along, and you can also support that patient after they're given medication in really amazing ways. But I do think it's important that if you want to work with this population, the endo patient community, they're not going to, get rid of their obstetrician or gynecologist. We want to work hand in hand and build that bridge, because I do think we have a really significant role to play with this population if we all hang out in the sandbox together. So as a quick review of the meds so that we have the respect that they deserve, they do better than anything we can do naturally at this point. If you have a mild or moderate case, and maybe they don't need medication, but for severe endometriosis, we can't beat the medication at this point in terms of pain relief. The progestins are actually the number one choice in this moment, so Dianogest being the number one choice. It's the cheapest option as far as medication options go, and it has the greatest effect. So best decrease in pain, return to work, reduction in analgesic use, all the things we care about for endo patients. Dianogest does win as far as outcomes. But your patients do have a couple of things to choose from with respect to medications, and that choice and the way you help them navigate that choice may have more to do with their preferences as a patient, what their side goals are, right, around contraception and maybe other symptoms that they have that we want improved by their medication. But Dianogest is, again, like I said, is number one, and it's the one that has the least effect of all the progestins on bone mineral density. So if you're as old as I am, you remember using Depo-Provera for endometriosis, which had a significant impact on bone loss. Dianogest does not have the same negative on bone mineral density that some of those earlier generations of progestins had. Okay, we see a reduction in lesion size, we see an improvement in pain, and we also see a low level of discontinuation. So I always say to my patients, if they've been online and read about Dianogest, they're like, oh, shock, horror, I've read terrible things about it. And I always remind my patients that nobody goes on TripAdvisor and writes about their mediocre chicken, right? People go on TripAdvisor and write about their food poisoning. And it doesn't mean that the restaurant is terrible, that one person has had a bad experience. When we look statistically at the information about Dianogest that we know to this point, patients generally have improved quality of life and are generally happy on it. The challenge with Dianogest is that there are some side effects that you may be able to support. We do have some endometrial atrophy while patients are on it, which may lead to some breakthrough bleeding. Some patients have vaginal dryness while they're on Dianogest, and we can solve both of those things with a vaginal estrogen. I gave you some of the indications there to be able to support that if you have that prescribing capability, or if you come across a patient who is on Dianogest. We should be seeing 2 milligrams prescribed at this point for standard of care. I occasionally still see a 4 milligram prescription walking around. It's no better than the 2. So we generally want to keep patients on the lower level. There are challenges with this around weight gain, which is probably a topic for us for another day, but I did put some pieces here for you. We don't totally know why patients gain weight on the progestin-only medications, but a food for thought that this is often one of the reasons the patients cite that they're worried about this medication. And then I did make another note about patients who are progestin sensitive that we may want to have a conversation about monitoring their mood going forward. Combined oral contraceptive is a great option, especially if we have co-symptoms that we're trying to support or treat, like acne or other things that the pill does very well, or even the mood symptoms that are related to progestin only, we may be able to solve with a combined oral contraceptive. Just a food for thought that I put this here for you. There are some newer combined oral contraceptives that are coming out that may be a better choice in patients with endometriosis. I put the Natassia option down there. It's not available in Canada, but depending on where you're tuning in from, that actually may be a better choice for your patients with endo based on the 2 hormones that are in that. We have great evidence for the IUD, okay? We do see a reduction in pain, we see a reduction in ovarian lesions, and we see a reduction in blood loss. All the things we've come to love and accept about the IUD, we see it improving patients with endometriosis as well. Doesn't get in the way of ovulation for most patients, and so we don't have the concern about bone loss with patients that are taking an IUD, okay? So I gave you all of the suggestions there across those 3 options. One of those 3 are going to be ones that likely your patients are offered either before they have surgery for endometriosis or after. And I think it's a really important piece. I kind of said this a bit earlier that we don't want to block patients from getting any medication for their endo. Remember I said at the beginning that the longer patients are in chronic pain, the less likely we are to be pain-free in the future because of that central sensitization. Even if we have like our ultimate goals of being medication-free at some time, improving pain immediately for patients with endo really goes a long way as far as quality of life. It also helps them re-engage with other parts of their health plan that we need them to engage in. Patients with endo have a lot of medical trauma. By the time they get to a doctor, they have mistrust in medicine. They have mistrust in the people who have supported them or have tried to support them because they often feel like their experience has been dismissed. And I always thought that one of my roles in supporting patients is to help them reestablish trust with medicine so that they could make a choice that was in the best interest of their symptoms, and then again helping support them. But there's really neat studies looking at even the coping strategies of patients with endo. By the time they get to a solution and we're like, here, this thing will help your pain, they decline it because they actually don't trust a lot of the solutions that are offered because their experience has been so terrible. And I always think that we have this amazing opportunity to have them have a better experience and trust in medicine that we're trying to support them. The last little thing I'll say about medication is that when your patients have surgery, they are going to leave with a prescription. And this is often shocking to both the patient and their integrative practitioner. Like I said earlier, cutting it out doesn't change their pain experience, and the relapse rates for endo are very high. It's very difficult for us to remove all of it by surgery, and so they leave with a medication. This was a really great study that looked at comparing medications. This is obviously a systematic review and meta-analysis looking at comparing medications when patients leave the hospital, if they leave with an IUD or they leave with an oral contraceptive, or if they leave with Dianogest, or if they leave with GnRH analog, which we didn't even talk about because it's kind of falling out of fashion at this point. Now, up here, you can see that it's swayed to the side, right? And what this is saying is that any medication versus watchful waiting, right? Any medication versus watchful waiting, and we see an improvement when they're on medication, didn't matter which one, okay? When we look at the GnRH analogs, we can see that that's not going so hot. That's why they're kind of falling out of fashion. But when we start to compare the medications that I just shared with you, they're equivocal. So whether they leave with an IUD or leave with the pill, they both seem to do the same thing. I really do want you to know that your patient will leave their surgery with meds, and that's actually the right thing for them to do, especially in those very early stages of patients being post-surgery and also wanting to be pain-free, okay? Really great question in the chat about fertility sparing. And at this point in time, and this is where one of your roles is incredible, at this point in time, there are no medical solutions for endo that are fertility sparing at the same time. And I don't mean that those solutions are fertility, like that they ruin someone's future fertility. I just mean in the moment, they're not fertility sparing, right? They block fertility. And so when patients have fertility goals, they will leave the hospital with no medication, right? Because all of those solutions prevent pregnancy. And so then your role even gets more amplified. So hopefully that makes sense for you. So these are just my summary around medication, but let's move into talking about the supplements and where I think things are going to go in the next couple of years so that you can have a really great role. Because of the timing of this webinar, we don't have time to go through nutrition. And when I do this education on a larger scale or a more in-depth training, it's about 3 hours. So I wanted to be really specific about what we talked about. We didn't really have the time to go through nutrition specifically, but there are some considerations. It's mirrored a little bit in the supplements, right? We see high antioxidant diet, Mediterranean style diet. The uniqueness is around low FODMAP, okay? Because those patients do have that, visceral hypersensitivity that is associated with IBS. There's often comorbid IBS in patients who have endo. And the reason for that is that central sensitization is that as soon as they're in that chronic pain state in their pelvis because of endo, they now have visceral sensitivity or hypersensitivity that triggers IBS. So there are some studies using low FODMAP diet in patients with IBS that helps resolve their symptoms because it decreases the pressure, gas, and bloating, as well as their experience of visceral hypersensitivity, which decreases their pelvic pain. Okay, how's that for a Cole's Notes version of nutrition? But generally, what's reflected in the nutrition, we see the themes of it show up in supplements. And I wanted you to see what you have available to you as from a toolkit perspective for supplements. Okay, so these are the ones that I want to cover. And specifically, you can see the theme here, right? There's kind of two sides to it. There is the antioxidant side of the conversation, and then there is the endocannabinoid anti-pain side of the conversation. And if PEA is new for you, this is a great nutrient that I would look at, especially if you work with a lot of chronic pain. The research on it is really great, especially for endo. We have some really neat outcomes for patients with endometriosis. But these are really the things that we're looking at. Of course, vitamin D, we want to treat deficiency in these patients as well. And we'll talk about where the research might be going with other solutions. I actually wrote a paper, when dinosaurs roamed the earth in 2009, when I had graduated, on endometriosis and the state of the world as far as supplements go. And I wrote about things like curcumin and resveratrol. And disappointingly, some of those nutrients have not been studied since. So we have some in vitro data on curcumin. We have a little bit of data on resveratrol. None of them have really stepped up and have had additional research on them since then. There's a couple brand new studies looking, again, they're like Petri dish studies looking at curcumin and endo. But these are the ones that have the clinical trial data and the ones that I would maybe choose more often, unless you had some other alternate reason to choose curcumin for some other reason your patient has and they have endo. I would probably stick to this list. So I'll be the first to say that the research on melatonin is emerging. The Petri dish and in vitro conversation is really fascinating. We see that melatonin suppresses the growth of endometriosis cells in vitro, and we have some studies showing a decrease in pelvic pain in patients who take melatonin who have endometriosis. The challenge is we have a couple studies that don't show improvement in pain, but the biological plausibility on this one is so strong. And because it's so safe and so cheap, it's one that I'm pretty happy to choose to support patients with. So we've got a couple of the articles there. We see improvement in pain and sleep. We see it compared to other pain medications and see some improvement. But what I really find so fascinating is the in vitro data. And if you've ever watched anything I've ever shared before, you know that this is not where I like to hang out in the in vitro space. I like real clinical meaningful endpoints. However, because we're missing, the number of studies and the breadth of studies I'd like on endo, I do think this is kind of fascinating. So when we expose cells to estrogen, so just to walk you through this diagram here. So when we expose cells with endo to estrogen, they grow, right? And I said that earlier. It's not the cause, but they're sensitive. When we expose the cells to estrogen, they grow. Now, in all studies, and there's a second one I'll show you, we also want to have what's like a kill control. It's called a kill control. So we also want to kill the cells, and they kill them in this particular paper with ethanol. In the other study, they use a different toxin. But they poured the ethanol on the endometriosis cells, and they also died. Okay, so they died. They die here under estrogen, they grow. Now, when they add melatonin in various concentrations to the endometriosis cells, the growth is suppressed, right? And it's not exactly the same as the kill control, but it's awfully close, which is really fascinating. And when they add the estrogen in, right, we would expect for it to have really significant growth. It's muted when we add it into with the environment with melatonin. This is a second study that demonstrates the same thing. They used a different kill control in this particular article. So we do think that melatonin as an antioxidant is having an impact on endometriosis growth and maybe having an impact on the replication of those cells. And we do see positives in some of the clinical trials. They're usually using about 10 milligrams in this patient population. I would say clinically, this is a great one to consider, especially since we also see papers with IBS using melatonin at this point for the visceral hypersensitivity. And now we see it for chronic pelvic pain in patients with endometriosis. Again, I'm a little disappointed by some of the research that's out there, but as a very safe and very inexpensive option, 10 milligrams of melatonin is a great place to start with your patients. The majority of literature is actually on vitamin C and vitamin E, which I always find so fascinating, right? I'm like, there are so many other antioxidants out there. Like, let's study some of the others. But really recent research and really, I would say, easy dosing of these supplements. And this is probably a reflection of like why the nutritional changes we make with patients with endo have a positive impact. But even just adding 1,000 milligrams a day of vitamin C and 1,200 milligrams of vitamin E per day. Some use 800, some use 1,200. We see a dramatic reduction in pelvic pain. So that's everyday pelvic pain, dysmenorrhea, which is pain with the period, painful intercourse. Okay, multiple papers here where we see that that dose of vitamin C combined with that dose of vitamin E decreases pain in patients with endo. Again, inexpensive, really easily accessible vitamins for patients to use. I wish I could say the same about PEA being inexpensive. It is not an inexpensive nutrient, but it is an endocannabinoid. Again, like I said, if you've ever looked at the chronic pain literature, hopefully this one has come up for you. We are seeing it show up again and again as discussion for chronic pain. The challenge with the endo literature is that it's often combined with an antioxidant that's found in resveratrol, so polydatin, which is another antioxidant that's found in resveratrol. The vast majority of the clinical trials are looking at a combination of those two ingredients. That is not commercially available, okay? The reason I'm comfortable using PEA, so this is, again, we're trying to talk about evidence-based decision-making framework here, okay? We can't replicate what's in these studies clinically because it's not available. Most of the literature on PEA for chronic pain is just on PEA. It's only the papers on endo that they've combined it with an additional antioxidant that none of us can buy. So I'm very comfortable using PEA alone in this patient population, especially if it reduces their use of analgesics. The side effects of PEA is zero. The side effects from most of the other things that they're considering choosing, since they have to use so many of them to control their pain, is problematic, okay? So generally pretty happy with this. We do think it's actually working on some nerve sensitization, which again, if we think about the central sensitization in these patients, this is probably one area that we can target that. Okay, so there are some review articles looking at sort of like visual analog scale data, and the pain is improved in patients with endo when they use PEA. In these couple of papers, they looked at like who are our responders versus who are our non-responders. And we do see an improvement in patients who have the ones with the best response are people who have painful intercourse. Okay, 82% of patients with painful intercourse were good responders to the PEA. We see generally good responder rate in patients who have pain with their period. Okay. So the vast majority of dosing for these papers is around 400 milligrams 3 times a day. It's a little bit of an expensive intervention for patients. However, even when we look at comparing it head to head against some medications, the medications often win, but not by a ton. And so it's interesting because this may be a viable alternative for patients who are looking to reduce their analgesic use. This was another paper looking specifically at some different metrics of pain. They looked at their quality of life, they looked at their daily functioning, they looked at their role in their daily life and if they were able to execute on it. And 90 days after starting the PEA, there was a statistically significant improvement across all measures. I liked this paper because they were looking at some unique variables like social functioning, right? Which we normally don't track in patients with endo, but they did see an improvement with those studies. So like I said, 400 milligrams BID to TID. Like I said, it's combined often with this additional antioxidant, but I'm very comfortable using PEA alone. There is research on ginger. I'm going to jump over it in the interest of time. My disappointment is there's not very much endo-specific literature for ginger, but I do want to call it out that the literature for dysmenorrhea is so strong. Again, I'm very comfortable experimenting with ginger in a patient. The thing I like about ginger the most is that how fast it works. So in this particular study, they saw improvement in the first cycle. And so again, inexpensive intervention, very safe intervention, and we should see a change. So this is the one that like stratified it based on number of months that they had taken it, improvement very quickly. And so I'm totally cool to try ginger because we should see improvement in one cycle. Okay, I put that right there. Okay, vitamin D, like I said earlier, this is one that we're going to test as part of our assessment. And this is very similar to other discussions on vitamin D that like having none is not very good, having enough is great, and having too much doesn't help. Okay, so overdosing on their vitamin D doesn't help. having just the right amount does seem to help reduce pelvic pain. So brand new study published in 2025. This is the beauty of medicine. Like, I'm sure there were studies published while we were talking. So now we are out of date immediately. But this is a great study by Jennings that was looking at all the literature on vitamin D and endo. And I actually really appreciated the way that they analyzed the data, trying to look at like, were the patients deficient at baseline? Like, how much did we give them? Did we retest them? Because so much of the vitamin D literature is just like missing what we would have done clinically. So they do see a link with vitamin D deficiency in the diagnosis of endo. Doesn't mean it causes it, but we do see a link there. And supplementation and correction of deficiency does reduce the symptoms of endometriosis, specifically pelvic pain. Okay, all positive. The rest of the studies are ones that were published prior to that Jennings article. They're all included in the Jennings article. That's the one that's just the most recent. A little bit of information on some other options like omega-3s, resveratrol, curcumin. There's one study on garlic, and there's some in vitro on quercetin. I like giving this here because this is like new and noteworthy, right? Like who's up and coming, hopefully future stars right here. I like you having this information so that if this crosses your desk at a later date, or maybe you and I get to talk about it at a later date, which would be wonderful, that these are ones that we say, we had high hopes for these guys. But I put them here for you. You've got lots to choose from the other options we discussed. I really don't jump to these as options. The last thing I want to talk about is exercise, which I didn't mention at the beginning. I love this little bit of literature on exercise and endo. And one of the things I'm the most interested in clinically.
Welcome to Rupa Health, the best place to order, manage, and track results from over 30 different lab companies in one single place for free. It's going to take you under 2 minutes to sign up, and you can order any functional medicine lab for your client in under 30 seconds. Let me show you how it's done. So here's our beautiful interface. I'm typing in the name of my client, selecting the lab that I want to order for them, and hitting send. From there, Rupa and their amazing team handle the rest. They email the client, collect payment, and even offer an interest-free 3-month payment plan. We've also built the world's largest library of information about chronic health conditions, the lab tests that can help you find the root cause, and the evidence-based interventions that you can use to help people heal from them. It's called the Rupa Health magazine. There, we have in-depth articles about almost any health condition you can imagine. And we give you step-by-step protocols that other clinicians have used to help their clients heal and that are verified by evidence-based sources. You should totally check it out, and it'll transform your practice. And we can't wait to see you. So make sure you sign up today at rupahealth.com.